The following program is brought to you courtesy of a grant provided by the Bank of Princeton.
Good evening. I'm Lou Goldstein, and welcome to another edition of Focus On. Tonight, as a part of Breast Cancer Awareness Month, which October is, we have on our show tonight Dana Holwitt, who is a doctor and breast surgeon at the Montclair Breast Center in Montclair, New Jersey. Dr. Holwitt comes to the Montclair Breast Center having completed a fellowship in breast surgical oncology at Washington University School of Medicine in St. Louis. She graduated from Colgate and earned her medical degree from the Virginia Commonwealth University Medical College of Virginia. During her residency, also at VCU, Dr. Holwitt was elected Surgical Intern of the Year and won the Basic Science Research Award. As a breast surgeon fellow, Dr. Holwitt was invited to deliver 2 presentations at the 2008 American Society of Breast Surgeons meeting and was awarded the Best Scientific Presentation Award for manuscripts that were published in the American Journal of Surgery. However, most recently, Dr. Holwitt was selected as one of New Jersey's doctors who make a difference by the New Jersey Life, Health, and Beauty in May of 2011, and was the feature story in New Jersey Monthly's New Jersey's Top Doctors issue last year. She was also a keynote speaker at the annual Young Survival Coalition dinner in May of this year. Dr. Holwitt, along with colleague Dr. Nancy Elliott, was invited to attend the first ever nipple-sparing mastectomy conference last February. Dr. Holwitt grew up in Montclair, New Jersey, and attended Montclair Kimberly Academy. She has long-standing ties to the community and looks forward to providing high-quality, personalized breast health care in this area for many, many years to come. So, Dr. Holwitt, welcome to the show today.
Thank you. Thank you for having me.
Well, thank you for being on. The first question I'd like to ask you really talks about the need for mammograms. There's been 2 things that have come out lately. Back in November 2009, there was a government task force that recommended women not have mammograms until they were 50 and then have one once every 2 years. The American Cancer Society recommends yearly studies starting and tests starting at 40 and having annual tests thereafter.
Right.
So I was wondering, if you'd give me your thoughts on the matter and your personal experiences.
Sure. You're absolutely right. There was a lot of controversy in terms of what the appropriate age to start screening for breast cancer should be. For many, many years, we've been following the American Cancer Society's guidelines, which is an annual mammogram at age 40. So you start at 40 and you get a mammogram annually after that. With that, they recommend a clinical breast examination with a doctor or some other healthcare provider. And then based upon other factors that can be assessed by your physician or your nurse practitioner, you can determine whether you need other screening modalities, perhaps for higher risk follow-up. In November of 2009, when the U.S. Preventative Task Force released their recommendations, there was a lot of uproar in the breast health community. Because what we know is that since we've started doing wide spread screening programs, that breast cancer mortality has decreased by about 33%. And the reason is that mammograms find breast cancers before you can feel them. And so they find them at earlier stages, and those are breast cancers that we can cure. So, by age 50, if you look between age 40 and age 50, you're missing a whole segment of the population who's already predisposed to breast cancer and who are already walking around with breast cancers in their breasts. I can't tell you the number of women I see between age 40 and 50 who are diagnosed with breast cancer. Thankfully, all of the other governing bodies, like the American Society of Breast Surgeons, the American Cancer Society, the American College of Surgeons, and the American Society of Radiology, put out statements very quickly after the United States Preventative Task Force released their recommendations and said, we don't agree at all. We think we need to stick with mammogram at age 40 and annually thereafter. Now, those are the recommendations for average risk women. In New Jersey and in northern New Jersey, where I practice, in particular, we tend to see more high-risk women, whether it be based on family history, whether it be based on other factors. And for those women, we really do recommend a baseline mammogram between 35 and 39, and then yearly from 40 after. And fortunately or unfortunately, that's the group that I fell into.
Right.
My mother was diagnosed in May of 2009 with pre-invasive cancer. She is postmenopausal. That's not a true risk factor, but I'm also an Ashkenazi Jewish female. And so I elected to get my baseline at age 36. And thankfully I did, because when the pictures came up on the monitor, I could clearly see that there was a breast cancer sitting in my right breast. So, those task force recommendations came out about 4 days after I had my surgery, and my doctors told me not to get my blood pressure above 120, and that's what I was watching on the Today Show. So you can imagine how happy that made me. But the bottom line is baseline between age 35 and 39, and yearly mammogram after age 40. And if there's any question about being high risk and you needing to change recommendation options, you should really be seen in a specialty center, a breast specialty center.
Now, you weren't unable to feel, your cancer, right, your tumor.
Correct.
So how did that happen, and how did you make the decisions for treatment after it was first diagnosed?
Right. So I was lucky because it wasn't a palpable mass. It wasn't something that I felt. It was something that showed up incidentally on my mammogram. Thankfully, as soon as I had my mammogram, I went and then had an ultrasound to confirm that it was what we thought it was, which was a breast cancer. And I had a biopsy that day. That was a Thursday. Friday morning, I went to work. I did a case, got my pathology back. It confirmed it was breast cancer. And then I had my breast MRI to look at both breasts. Now, that's a very sensitive test that we reserve for high-risk screening and for women who meet that criteria. But we do use it to evaluate the extent of disease within the breasts once somebody has a diagnosis of breast cancer. And then I had to, take a little time and sit down and talk to my family. Because I think you know what you want to do,
right, until
you're diagnosed. And then it becomes very real. So I did a lot of talking with my parents. My father's a surgeon as well. I did a lot of talking with my friends. I did a lot of talking with my colleagues at work. I sat down and I did a lot of alone time thinking. You have to know yourself and what you're willing to tolerate and what you're not willing to tolerate. And ultimately, for me, I wanted to choose the surgery that was going to get me back to work the quickest. And I wanted to choose the treatment option that was going to allow me to focus more on my patients and less on myself. And for me, that option was mastectomies. But I certainly could have had a lumpectomy and radiation. And the outcome, my outcome was not dictated by which surgery I had.
So you chose double mastectomy.
So I chose bilateral mastectomy
Right.
For my very personal reasons. And I think it's a very important point that, part of going to a specialty center and part of seeing a breast surgeon when you're diagnosed with breast cancer is that you have many, many options that are available. And it's a partnership between doctor and patient to ultimately determine what is going to be the best treatment surgically for that particular individual patient's cancer. We don't do things cookie cutter anymore.
Does it improve the overall survival rate?
Doing mastectomy?
Yes.
It does not improve survival rate. It does decrease the chances of breast cancer coming back locally. So
Okay.
it has a slightly lower local recurrence rate than lumpectomy, but whether or not breast cancer comes back somewhere else in the body is not altered one bit by whether you have mastectomy or lumpectomy and radiation.
Yeah, I was reading your story, and you also said that doctors have to try and understand their patients and not just the disease. Could you explain that a little further?
Yeah, I think that in medicine we're so protocol driven because things have been so well studied that we know what the board answer is when somebody says you have a patient who's diagnosed with a 2 centimeter breast cancer, and in your mind you're going through, okay, I need this study, I need to know this information, we can do this operation, we can, you're fine for a lumpectomy, I'm going to recommend lumpectomy. Well, that's all well and good. You've proven to me that you're a very smart doctor and that you know how to manage breast cancer. But until you've walked in someone's shoes and you've lived their life and you have a better understanding of the anxiety that surrounds, close follow-up after a diagnosis of breast cancer, or even the anxiety surrounding coming in for your yearly screening, it's really difficult, to say you don't need a mastectomy or you don't need to remove a healthy breast. And I think that was, I was answering that question when I made those comments. I was actually responding to an article in the New York Times where they had discussed the increasing rate of mastectomy and the increased rate of bilateral mastectomy, so removing a healthy breast in women who are under 45. And they were trying to figure out what are the reasons that the mastectomy rate seems to be increasing. Well, I'll tell you, when you're 36 years old and you're diagnosed with breast cancer, you're facing 30, 40, hopefully 50 years of continued monitoring. If you have radiation, then you're going to be dealing with the long-term effects of radiation, which are not, horrible, but they do exist. And it can paralyze you. It can impact you so much that you can't focus on anything else in your life. And being the patient, all I wanted to do is get back to my normal life. I wanted to be working, I wanted to be with my friends and my family, and I wanted to feel healthy. And so I made the decision that I needed to make to get me to that point. And I think that other physicians need to be sensitive to their patients, and they need to really take the time to get to know a little bit more about their patient's psyche before they close the book and say, well, you're good for a lumpectomy, and lumpectomy is all I'm going to offer you.
What impact does genetics play?
Well, genetics plays a big part of everything that we do in medicine. For breast cancer, there are about 5 or 6 genes that have been identified that have hereditary breast cancer as part of the syndrome. The 2 most common that people talk about are BRCA1 and BRCA2. But genetic breast cancer accounts for only about 5% of the breast cancers that we diagnose in a year. So 85% of the breast cancers have no, pre-existing significant family history or no known genetic mutation.
Okay.
So people who are mutation carriers, we identify them by doing very thorough family histories. We identify them and then we test them. It's a blood test. And those women and their families are screened differently than the average person. And that's a whole hour-long, sometimes 2-hour-long discussion. But people who have very significant family history of breast and ovarian cancer, especially in younger women, or anybody that has a male relative with breast cancer, absolutely needs to be seen by a breast specialist.
Okay. Now, where there's a history of cancer, be it breast or otherwise, and I have 2 daughters, okay? And so where there's a family of history of cancer in the family, should teenagers or young adults be tested earlier? You mentioned, I think, the BRCA genes, and whether or not that would be something that,
Right. Well, so for BRCA carriers, for women, in families with known BRCA1 or BRCA2 mutations, we generally don't start following them with high-risk screening, with imaging and things like that, until 10 years prior to the youngest person who is diagnosed. That usually falls in the 20s. There are no hard and fast guidelines that are put out by any of the governing bodies, whether it be the NCCN, which is responsible for putting out guidelines for how we treat all different cancers, or the American Society of Breast Surgeons. But I think as a community, we've come to the agreement that, starting to talk about testing at age 25 seems the most appropriate. Because, just because you carry a genetic predisposition doesn't mean you're going to get breast cancer. And you really need to have, some life experience and be mature enough to understand what the implications of testing positive are, and be willing to, either adhere to the screening, follow-up, and medical treatment, or be able to digest and fully process the idea of prophylactic surgery. So removing healthy body parts to prevent cancer from developing. And I think if you're younger than, 25, it's really hard to, it's hard to have that conversation. I just don't think that the maturity level there is there yet.
You mentioned how you processed the information once you were told that you had breast cancer, and everybody's different. What can you say to someone who has just been diagnosed, or what do you say to someone who's been diagnosed with breast cancer, and or what do you say, there's a follow-up question to an answer you haven't given me yet, but what would you say to an individual who does not want to have any type of mammogram done, and they're afraid to find out?
Okay. Well, to answer the first part of the question, what I would say to somebody who's diagnosed with breast cancer is that, in 3 seconds, your life changes forever. And you are going to experience more emotions than you even knew were possible. And that's normal. And you should allow yourself to experience those emotions. You need to surround yourself with really supportive family and supportive friends, and then you need to shut the phone off and shut the world out for a few days and just really sit and think about what's going to make you happy. Because what generally happens is, if somebody finds out you've been diagnosed with cancer, and all of a sudden every friend, family member, sister of a friend picks up the phone because they want to be helpful, and they call and they say, you got to go here, you got to go do this, my Aunt Sally had this done and she did horribly, and you just have to shut the rest of the world out. You surround yourself with your support system, and you and your support system and your team of physicians need to be the ones helping you make your decision. You're allowed to feel sad, you're allowed to feel angry, you're allowed to have a little bit of denial. It's the same thing you go through with 7 steps of grieving when you have a loss. It's the same 7 steps of grieving that you go through when you're diagnosed with cancer. And that's okay. But then you gotta put everything back together, put your head on straight, and make a decision and start your treatment. And know that breast cancer is not a death sentence. I mean, I was diagnosed in October of 2009. I had my surgery in November of 2009. I started chemotherapy on New Year's Eve, and I worked almost full-time throughout my whole chemo. So it's not a death sentence, and treatment is very well tolerated these days. And I think that there's a lot of misconceptions about breast cancer treatment. So that answers the first part. Now the second part of the question is, what do I say to women who don't want to have mammograms or don't want to know if they have breast cancer? My first question is, well, you've come in to see me, so it obviously concerns you. Why don't we talk about what you're afraid of in terms of the mammogram? What is it that you're afraid of? Is it the irradiation that you're afraid of? Is it that we're going to find something that you're afraid of? Because mammograms are very low dose radiation. We don't start them generally till you're 40, so that the cumulative dose is low.
Okay.
So it's very rare to have an adverse outcome from cumulative radiation from a mammogram. And if it's that you're scared we may find something, putting your head in the sand is not going to alter whether you're going to develop breast cancer or not. But what it may do is it may make you diagnosable at a later stage when I can't cure you, versus diagnosed at an early stage when it's curable. That's the difference. So again, it's about a little bit about being part therapist for your patient, finding out what it is they're afraid of, and addressing those issues. And 9 times out of 10, they say, okay, no one's ever explained it to me like that, and now I understand why I need it. A lot of the misconceptions are all about miscommunication. And if you have a conversation and you listen to your patients, 9 times out of 10 you can resolve any problems that arise.
That's good. It's good. Well, it's all about communication. But
Absolutely.
I also think, too, that people tend to think about treatments, and the treatments that they may have to go through.
Right.
And from personal experience, without belaboring the point that you already discussed, what was going through your mind as you went through the various steps of the treatments, as you went, like you said, on New Year's Eve? You know how to party,
Yeah.
start your treatments on New Year's Eve.
It wasn't chosen by random.
But what was going through your mind at each stage of the treatments?
Well, before I had my surgery, I was focused a lot on what is the pathology going to show, what is the status of my lymph nodes, how big is the tumor, because those are the kind of things that go into determining stage and prognosis. Once I had that information available and we determined that I did need chemotherapy, but it was an early stage breast cancer, I put my mind into chemotherapy mode. I mean, I talk to people all the time about chemotherapy. Never in a million years did I think I was going to be sitting in, that infusion room getting chemotherapy. But, I talked to people, I talked to my patients who had gone through the treatment I was about to get. They were a tremendous support for me. I talked to friends who had gone through it. So I felt prepared. Obviously I knew the stuff that I can learn in a medical book, but I didn't know there's lots of things that happen to you when you go through chemotherapy that you can't read in a book. And so it was nice to have people give me their little pearls of wisdom. The first day of chemo, I was scared. And I think anybody who's not scared is lying. It's scary. You don't know what your body's going to do. But after getting over that first hump of the first chemo treatment, everything else just kind of flew. It went very smoothly. I knew what to expect. I knew, how to make my work schedule so that I was not there when I was the most tired. Fortunately for me, when I had my second 12 weeks of treatment for the second part of my chemotherapy regimen, I only had to do it once a week, and I had virtually no side effects. So I would do it Friday afternoon, and I'd only miss half a day of work. So, the thing for me that got me through my treatment was keeping my life as normal as possible and not sitting on the couch and feeling sorry for myself and, why did this happen to me? But recognizing that breast cancer and cancer in general doesn't discriminate. It doesn't care who you are. It doesn't care what you do. And you can choose to, to shut down, or you can choose to live your life and kick the cancer in its butt, which is what I chose to do. And which is why I chose to share my story, because I think it's important for people to see that there is life during and after breast cancer,
What's the likelihood, in talking about fertility rates, what's the likelihood of a cancer recurring, if you get pregnant? And what's the likelihood of not being able to get pregnant due to the treatments?
Those are hard questions to answer. It is true that chemotherapy generally puts you into a pseudomenopausal state. It causes your ovaries to shut down. For my particular tumor, it's estrogen sensitive, so I'm also on tamoxifen. And I don't know if I'll come out of the pseudomenopausal state. Some women do, and many women get pregnant and have children after breast cancer. Some studies show that having a pregnancy after breast cancer is actually protective. Some studies show that maybe there's, a slightly increased risk of developing breast cancer. I don't think that the medical oncologists and, the oncology societies would say that it was safe to get pregnant if it wasn't safe. But that has to be a very personal choice. Some women don't have that choice. Some women do become menopausal after they go through treatment. But I think that there's a million ways to build a family, fortunately. And so carrying a child is not the only way to become a mother.
Okay. What are some of the things that you would want to tell people who are viewing tonight, and especially women who are viewing tonight, and may want to support individuals that they know who may have breast cancer, or who may be afraid to even go to the doctor because, as we talked about, their fears? But more, what type of supports can you give right now?
Yeah, I think that the most important concept I'd like women to take away from this is that the value of getting a quality screening mammogram cannot be overstated. So you need to do a little research. You need to find a place where they do either 100% breast imaging or the majority of what they do is breast imaging. And you want to know that the person reading your mammogram is either fellowship trained or has done extensive work in mammography, because that is the tool where breast cancers are found at stage 0 and stage 1.
Okay.
And those breast cancers are curable. Being afraid of being diagnosed with cancer is normal. Nobody wants to be diagnosed with cancer. But again, putting your head in the sand and pretending that, just because you don't go, it's not going to develop, that's not how it works. It just means that you may be diagnosed at a later stage. So a lot of women go in groups. They'll go with their friends. They'll pick a day, whether it's in October for Breast Cancer Awareness Month, and they'll come as a group. And that way they can, it lessens the anxiety a bit. The other thing that's maybe a little unique to our practice at the Montclair Breast Center is we give our radiology results the same day.
Yeah.
So a lot of the anxiety about not knowing whether you're going to get called back if you need a biopsy, that's eliminated. You know when you leave our practice whether you're good for a year, you need to come back in 6 months, or you need to have a biopsy.
So before you go out that door,
Before you leave the door, you know the results of the mammogram. We've already done the extra pictures. We've already done the ultrasound. Sometimes we can even do the biopsy the same day. So we recognize the anxiety, and we've made changes in our practice model to deal with those anxieties.
Okay, now I know you have a special symposium coming up at the Montclair Breast Center, the second annual symposium of genetic breast and ovarian cancer and
Yep.
women at high risk, and it's going to be on Saturday, October 15th from 9 a.m. to 1:30 at the Women's Club, 82 Union Street in Montclair.
Absolutely.
And I thought maybe you could talk a little bit about that.
Sure. This is as you said, our second annual high-risk symposium. We do see a fair number of high-risk family history women in New Jersey, as well as BRCA-positive patients and women who are just interested in learning more about hereditary breast cancer. And so we put together an excellent group of speakers, some from New York, some from New Jersey, to discuss issues about genetics, to discuss issues about surgical procedures and what's the latest in terms of options. We talk a lot about nipple-sparing mastectomy, which is a really hot topic right now. We're going to have a reconstructive surgeon there to talk about reconstruction, and then an actual patient, a psychologist, and our lifestyle expert who helps us in terms of overall general health and risk reduction. So it's a nice group of people. It's a very casual kind of atmosphere. It's a safe atmosphere. And for women who are watching who are high risk or who have a BRCA mutation who feel like they have no one to talk to, this is the perfect kind of opportunity because it puts us all in one room and you can get a lot of questions answered. So if you need more information, you can go to our website. It's www.montclairbreastcenter.com.
Okay. Hopefully we'll see some people there on Saturday, October
Love it.
15th. And it's an educational program, and everybody should, if you're in the area, please, or make it at your business to attend. And if you're hesitating about getting a mammogram, please get it done and follow up. And Dana, it was lovely having you on the show tonight.
Thank
you are
you.
my hero for what
Yeah.
you're doing, and also for getting the word out for other people and dealing with a very, very important issue and talking about it. So I'm Lou Goldstein for tonight. That's our show for tonight and for Focus On. And we would like to tell you to stay healthy, to stay involved, stay focused, and remember, stay healthy and be well. We'll see you next week on Focus On.
This program was brought to you through a grant provided by the Bank of Princeton.